Kevin Turner, a neonatologist. I work at Orange Park, and my wife is operating camera, and she's going to be interviewing me for Jane. You have this disease we're talking about, which is persistent pulmonary hypertension of the newborn, PPHN. So what that means is you have a failure to convert to the adult circulation. So you have an appropriate rise in your peripheral blood pressure, but you do not have an appropriate fall in your pulmonary blood pressure. And as a result, there's not really a difference. Or if there is a difference, it may be only barely favoring one or the other. And the problem with that is now you cannot perfuse your lungs. You cannot get oxygen into your lungs, which therefore means, since you're no longer plugged into mom, you cannot oxygenate your body. You can't ventilate your body. This disease process has a lot of etiologies. The most common is what we call idiopathic, which means we don't know what causes it, but there's a lot of known reasons that also cause it. You can sneeze. Infection can cause it. Meconium aspiration can cause it. The best first medicine to treat failure of the fall of the pulmonary blood pressure is oxygen, because when those small arterioles in the lungs, in the pulmonary circuit, see oxygen, they relax and dilate, and it brings down the blood pressure. So the reverse is also true, and this is why these babies get into such catastrophic, life-threatening episodes. If they are hypoxemic, that causes a spasm of that pulmonary blood vessel, which, by the way, prevents blood coming into the lungs, which causes more hypoxemia, which causes more spasm, and prevents even more blood coming into the lungs. And so you kind of see this downward spiral. The other terrible process for the lung dilating is acidosis. And so if you've got no blood coming into your lungs, then you cannot ventilate. So you're developing some respiratory acidosis. And if you are not oxygenating that blood, then all your tissues are becoming acidemic also because of anaerobic metabolism. So you also have a rise in your acid level, fall in your pH. And so that does the same kind of downward spiral. As soon as they get acidotic, those blood vessels spasm and they start to cause even less perfusion into the lungs, which means even worsening clinical status. So again, the primary therapy is oxygen, because when you give oxygen, it causes relaxation. In this situation, the reason nitric oxide, which by the way is only a gas, it's only inhaled. I don't know of any systemic nitric oxide that they have. The inhaled nitric oxide is wonderful because when a baby breathes in nitric oxide, they're clearly breathing that into a ventilated area of the lung. And when they breathe that in, that ventilated area of the lung instantly is sending a signal out to the pulmonary vessels. Dilate open right here. So it actually fixes these ventilation perfusion mismatches, because the area that is being ventilated suddenly now becomes better perfused. And it also acts on that local pulmonary vasculature to relax them and dilate them open. So there are a couple medications that we use, not so much in neonates, but that can enhance the endogenous production of nitric oxide. A couple medical things we can do, but in terms of vent management, the next best thing you can give is nitric oxide, inhaled nitric oxide. This is a chemical that we knew for a while must exist. We just didn't know what the chemical was. I think they even called it factor X, but they knew there was something that cells were producing that caused vasodilation, and they just didn't know what that was. And when it was discovered that it was nitric oxide that the cells produced locally to cause local vasodilation, that instantly became a wonder drug for these situations. And I'm going to use meconium maceration as a really good example as to why this can be such a wonder drug in this situation. So again, it's falling on its own. And like I said, primary therapy is oxygen. Then we do some medical therapies, keeping them calm, because agitation can cause increased vasoconstriction of the lungs. Obviously, intubating them and ventilating them so that we can give them 100% oxygen with a generous medial air pressure, trying to make sure that they're oxygenating as much as they can. Sometimes those ventilation strategies based on if there is or is not air trapping from meconium plug syndrome Meconium are the little ball plugs in the lungs. And we use inhaled nitric oxide as kind of our last-ditch effort, second to last-ditch effort. Although I think it's a wonderful medication, I think it's also really expensive, which is probably why we start with oxygen, do the medical therapies usually next, and then the inhaled nitric oxide next. The last ditch, if all those don't work, is something called ECMO, which is a heart-lung bypass, really morbid on babies to do, and usually that process alone, they don't survive much longer than a few